We'll come to the last talk, relevance of posterior segment evaluation in children. Over to you, madam.
Thank you, Ramya and KSOS for this opportunity. So what is the relevance of posterior segment evaluation in children? So just like in any case, it is very relevant because the prognosis of the child's condition totally depends on the posterior segment health. So, but it's a very challenging task in children because children don't complain. And so you have to have a high index of suspicion about the posterior segment abnormality and do the necessary investigations. There may be diverse pathologies and there is a technical difficulty in examining the child. So you may even have to do an examination under anesthesia. So, and when should you do a detailed posterior segment evaluation? Most of the time, you're just able to get a glimpse of the posterior pole, disc and macula, and that's it. In children, you can't do a detailed peripheral examination. Ideally, you should do in all cases, but in certain cases, you must do a detailed examination. And which are those? Definitely in premature babies, when you're looking at ROP. I'm not going into detail because I think there is an entire session on ROP in KSOS, but prematurity does remain the first condition. Then any child with an unexplained vision loss, you must do a detailed examination. Any child with poor vision, which you cannot explain, with nystagmus, with sensory strabismus, trauma, definitely you should do a dilated detailed examination, pre and post surgery, especially a cataract surgery patient. When you're suspecting ocular tumors, suspected syndromes, which are referred by a pediatrician or a neurologist to you to look at the fundus and give them inputs, and systemic conditions. So these would be a bunch of conditions in which you would definitely have to sit down and do a detailed examination. How to do a posterior segment evaluation? Just like in adults, but it's again different because most of the time in a regular OPD, you're just able to do an indirect ophthalmoscopy with force. You have to ask the sister, as Ramya showed, put the child down and do, or if the child is cooperative, you can do an indirect along with the slit lamp biomicroscopy by making them sit, kneel, or stand on the slit lamp and get a good look at the macula. Fundus photography definitely helps, especially with the advent of optos. You actually get an entire peripheral view of the retina and you may pick up lesions which you have missed. In children in which there is hazy media or not a good view of the fundus, definitely you must do an ultrasonography B scan to document the posterior segment. And with the help of OCT, we can actually know more about the pathology. And in suspected cases of unexplained vision losses, definitely you have the electrophysiological tests of electroretinogram and VEP to your aid. So let's look at some illustrative case scenarios. So this was a case of an 8-year-old boy who was detected to have accidental vision loss in the left eye. His visual acuity in the right eye was 6/12 and left eye was counting fingers 2 meters. He had compound hypermetropic astigmatism. So was it amblyopia? On asking repeatedly, they said there is family history of poor vision in the paternal grandfather and in the uncle. So this is his fundus picture. I don't know if you can see. The right eye essentially looks normal, but in the left eye, if you see, there is a linear area of subretinal fibrosis, which you may actually miss if you don't do an indirect ophthalmoscopy and a 90D examination. And there are some foveal changes. The foveal reflex was not good, and peripheral examination showed some pigmentary changes. So that's when we got this optos. So you can see nicely the optos is showing beautifully what he's having, and he was cooperative enough for an OCT, and you're seeing schitic changes in the fovea. So before labeling any child as amblyopia, please make sure that he's not having a pathology, and he turned out to have a juvenile X-linked retinoschisis. So it is important that you document this, and in cases which you cannot explain, at least refer them if you don't have the necessary investigations at your place. So this is a typical bicycle spoke wheel maculopathy, which you can see on 90D, but otherwise OCT will pick it up. So this was another case of a 5-year-old girl brought again with squint, left convergent squint. The eye was a little smaller, and she had a best corrected visual acuity of 618 N8 with a -5 sphere and a -2.5 cylinder at 120 degree. So again, very important to look into the fundus before you say it is just refractive error causing amblyopia. See, what you see is she has a large optic nerve head coloboma in the left eye. Yes, we will definitely give glasses and patching to this child, but you have to give a guarded prognosis to the parents that the vision will never be as good as the right eye. So that is the importance of posterior segment evaluation. So this was another case which was referred as traumatic optic neuropathy, defective vision after trauma. Left eye was good, right eye was 618, N12. No RAPD. Very important, you yourself check the pupil and the color vision. And fundus was looking normal, but the right eye, the foveal reflex was dull. We got an OCT done, retinal nerve fiber layer was good. Is it an with the no RAPD, I was sure it was not traumatic optic neuropathy. We looked into the macula with OCT, and what you see is a scar. So this is a traumatic maculopathy. Again, you have to explain to the parents, yes, there is a problem with the trauma, and with the pictures, you can actually tell them what has gone wrong in this patient. So posterior segment evaluation in cataract surgery patients is a must because it is important not just for the prognosis, but you don't get any intraoperative surprises. So all the tests that I've described can be used, but a basic B scan definitely should be done in suspicious cases. So this was a 1-year-old girl with intermittent exotropia of the left eye. She had a central cataract. So she was not cooperative for slit lamp examination. This is her intraoperative picture. But I put her down and I saw that the fundus I could see, but there was a suspicious stalk running from the optic nerve her to the posterior lens capsule. So my doubt was, is it a persistent fetal vasculature? But when we did a B scan, it was absolutely normal. See, no stalk. Axial length was good, around more than 20. So everybody said this is not PFV. Anyway, I kept the suspicion in mind, and this is what happened intraoperatively. You can see post-lens aspiration, there was a plaque on the posterior lens capsule, and can you see the stalk? This stalk running from the optic nerve to the posterior lens capsule. Sometimes it will bleed. When you do the posterior rexus, it will bleed and you can produce massive vitreous hemorrhage, and you may have to call the posterior segment surgeon. But because I had the suspicion in mind, I was able to cauterize it with the endocautery and avoid the bleed. So that is the importance of pre-op examination. So this was a case of a mild form of a combined PHPV. So Dr. Coker has described this technique in which he uses a retinal lens after lens aspiration, fills the AC with viscoelastic, and uses an endo-illuminator to illuminate and look at the fundus. So, but we can anyway do an indirect ophthalmoscopy in a sterile manner after the lens aspiration to look at the fundus if you have not seen it before. Another case of a myelinated nerve fiber, again will be referred to you as amblyopia, but look at the extent of the myelinated fiber. So there is a triad of severe myelinated nerve fiber, high myopia, and amblyopia. So this is Stratsman's syndrome, and it is not going to improve. It's a case of refractory amblyopia. There is a structural problem, thickening of the nerve fiber layer at the disc as well as in the macula, and it's not going to improve. So this is the importance of explaining the prognosis to the parent. So I think the time is over. So sometimes in systemic conditions like tuberous sclerosis, you may be asked to look at it, and we was able to pick up the hematomas with the help of the OCT, and we published it. And this is the last case referred again by pediatrician to rule out a retinopathy because he was suspecting some condition, and we were able to document with ERG, flat ERG's retinal dystrophy. It turned out to have this eye of the tiger appearance on MRI, and it was pantothenate kinase deficiency. Again, juvenile glaucomas can be picked up. Can I take 1 minute? There is time, yeah. So this was referred as a neurological cause, but if we look carefully, she had large cups with hardly any neuroretinal rim. Child was tripping and falling off, and RNFL was very thin. She had borderline high IOPs. This was a case of juvenile glaucoma. She underwent trab with trab and did very well. And optic neuritis, again, be careful before you label it as optic neuritis. Do a B scan and an OCT FAF to make sure that it is not optic nerve hydrusen, which was the case here, and we could tell the parents. So again, post-retinoblastoma treatment, you may be asked to follow up. Again, you have to do a detailed fundus examination, dilated. Sometimes you have to do an EUA because you shouldn't want to miss any new lesions. You can see the regress retinoblastoma, cottage cheese appearance here. So I think this summarizes the various cases in which you would do, and thank you, Ramya, for this opportunity.